My goal tonight is really to give a little bit of insight in how we can talk to first responders at home, also how to identify some maybe warning signs of suicide, as well as maybe some tangible skills we can take away and try with our first responders at home. So I'm going to cover quite a few different things tonight, giving you a snapshot of different skills and different background information, knowing that although I'll spend about a half hour talking tonight, there's a lot more that I'm happy to share, as well as additional resources after this, and I can work with Michelle on getting those distributed as well. So what I wanted to start with tonight, there we go, is talking a little bit about understanding suicidal behaviors, so that we all have kind of a baseline understanding of where suicidal behaviors come from, and some of the research that's been done on it, but it's really applicable for every person that I interact with, especially first responders, and understanding why they may have these thoughts or even attempt to hurt or kill themselves. So researchers have looked at this for a while now and have come up with a pretty simple model. And I'll promise you that we're not going to stay in Psych 101 for too long, but I do want to talk about negative reinforcement and positive reinforcement, where positive reinforcement is adding something and negative reinforcement is taking something away. And then we have those internal or external cues. So when we've looked across suicidal behaviors and kind of understanding why do people try to hurt or kill themselves, it's come out to be kind of this 2x2 box. And what I always like to say right after I say it's a 2x2 is that it's not that we're putting each individual into one of these categories, but it actually might be several of these categories. But it gives us a framework to work from and to look at when we're talking to people about suicide, when we're hearing other people talk about kind of what's going on in their life. And so if we start in the upper left corner, the positive reinforcement and internal or automatic, what we hear people say sometimes is that they want to add something desirable, or I want to feel something is really what we hear people say. If we go to kind of the positive and external, this is adding something to get attention from other people, and sometimes called the attention seekers, which is pejorative language that we want to try to remove. But it's often people who don't know how to talk about their feelings or kind of the overwhelming sense that they're getting. Sometimes that's a body response or physiological response, but they want to let people know things aren't going well. And so sometimes they're coming to us in crisis or in a panic, and they want us to know, and they may say things like, I'm going to kill myself. You know, afterwards they may say, I have no intention of doing that, but I was feeling so overwhelmed, I didn't know what else to say. If we go to the top right, this negative and internal, this is actually the top thing that we hear individuals who have had a history of suicide attempts or that are high risk for suicide. They really say that I want to stop feeling bad. And I think that's really, really powerful and something that we often hear people say, I don't want to feel this way anymore. You know, and this can happen with first responders after a rough day at work, being exposed to different traumas or events. I'm feeling overwhelmed, I'm not feeling myself, and I just want to stop feeling this badness or this way that I'm feeling. And then the last one in the bottom right, sometimes we have people who the negative reinforcement and external cues, where they're trying to kind of get out of interpersonal tasks or demands. They want to avoid punishment or doing something. I don't want to go back to that, so I'm going to say that I'm going to hurt or kill myself. That one's pretty rare, actually. But again, kind of the big takeaway from this is that the kind of most common reason that people say I try to hurt or kill myself is I don't want to feel bad. I don't want to feel this way anymore. And so when we're talking to first responders, whether they're our partner, our spouse, even on the job if we are first responders ourselves, is what are we hearing people say? Are they saying things like that we might be able to pick up on? And then later today or tonight, I promise I'll talk about how we can ask about that and where we can go with that and what maybe tips and skills that we might be able to do with them. The other thing that I want to point out, just some background about suicide, is often people think of suicide as being very impulsive, that it came out of nowhere. And what we actually see now across a lot of data on suicide is that these individuals are actually really resilient. And so they're trying really hard and stress is overwhelming for them. So if we look at this curve here, let's see if I can pull that up, there we go. So this curve here, on our x-axis, we have emotional distress or not feeling well, and our y-axis, or across the bottom, we have time. And what we see with high-risk suicidal individuals is that they're going along and things get stressful in their life, and they try to cope with it. So they have different coping skills, let's say going for a walk or exercising, meeting with friends, going to a game night, different skills that they have. And what happens is over time is these people who are high risk for suicide start trying to use those coping skills. And what happens is one time the coping skill doesn't work, or maybe one or two times the coping skill doesn't work. And so what they start to say to themselves is, oh, so you know what, exercise used to make me feel good, and now it doesn't. So I'm not going to exercise anymore. And we've lost one coping skill. And so they go along and they get put in another stressful situation and they have one less coping skill. And this goes on and they're put in all of these stressful situations. When we think of first responders, there's a lot of stress within the work, regardless of kind of what department or what position you're in. There's a lot of stress related to that and repeated stress. So you're put in these situations to respond to traumas and to events. And so we know that within first responders, there's a high rate of that. So it eventually gets to a point at the top here when you get to that red line that says, I could just kill myself. And so this is where people feel so overwhelmed. They feel like they have no coping skills. They may feel even like they have no reasons for living or no meaning in life. And they finally get to that point where they say, I could just kill myself. I want to end it. That prepping period on this graph is where it's very quick, minutes to hours often. And that's where we see then a suicide attempt often. And so the reason I like to show this graph and kind of data behind this is that we would love to catch people when they're on the left side of that red line. So when they're starting to feel overwhelmed, they're trying to do different coping skills and they're starting to discredit or stop using different coping skills. And how can we then intervene there? So part of that tonight, we're going to talk about what are some of the warning signs, what are some of the things that we can do, can we help them get those coping skills back, can we help them remind them of their reasons for living or their meaning in life, and can we help kind of with this curve stop it from getting to that red line or that point of saying I could just kill myself. The thing I always like to mention is when we have someone who has a suicide attempt or has attempted in the past, and whether that's one attempt or multiple attempts, all of the things that I'm talking about tonight are still applicable. And we want to make sure that we can give them kind of some of that sense of power and control back in their life and help support them as they go through still being often in a first responder capacity and on the job. What can we do to help support them at home? So with that, I want to talk about just a few myths about suicide here that often come up. And I'll also, at the end of this presentation, there will be links to a couple pages that talk about some more myths, as well as give a little bit more detail about some of these myths that I'll briefly cover tonight. The four that I want to talk about is first, that talking about suicide will lead to a suicide attempt. There's actually some great data, a few studies out there showing that talking directly about suicide, whether that's the actual suicide attempt, whether that's non-suicidal self-injury or self-harm, asking directly about those things does not increase the chance of a suicide attempt. And I think that's something that's really, really important to take away, and something that the kind of suicide field has been trying to get out there, that we want to be asking these questions directly, and we want to be having these conversations, and we want to go into those conversations being prepared ourselves for what that conversation is going to be about, and where we're going to go with that conversation. The second thing is that suicide only affects people with mental health diagnoses. There's some great data coming out pretty recently from the CDC, as well as from a few other researchers, showing that if we look at death by the means of a gun, about 50%, right around 50% of people who die by self-inflicted gun shot do not have a history of a diagnosis of a mental health disorder. Now, there's a whole lot that we can go into and break that down and say, you know, some of them may not have gotten treatment or gotten diagnosed, but having still 50% of those people, it seems like there's a pretty large portion of people who don't have a mental health diagnosis. And that's going to come up as we talk later tonight on how we can have this conversation and ways that we might be able to help reduce the chance of death by suicide. The third is that death by suicide occurs without warning signs. Now, I showed you that curve graph showing you that these individuals often have a good amount of time before a suicide attempt occurs, that they're trying, that they're resilient, and that they're using their skills. So there are oftentimes warning signs. Now, what I want to mention is that there aren't always overt warning signs that we're easily going to pick up on. The phrase, you know, hindsight is 20/20 comes up a lot within suicide research and in clinical practice as well. And so what I want to mention about this is that although there are some warning signs that we can look for, there are times where we will not see the warning signs. But hopefully tonight we can give you some insight onto what we might be looking for at home and with our first responder. And then the last one I want to talk about tonight in terms of myths is that people who talk about suicide are just seeking attention. I talked a little bit about attention seeking a couple slides ago, but what I want the take home to be here and what the data show is that often again, these people who are maybe saying things about I want to hurt or kill myself, or I'm going to kill myself, is that they aren't always able to communicate how they're feeling or what's going on. And it may be that they don't necessarily have the language, they don't know how to communicate it. Maybe it feels like I'm always angry and I can't really tell you what else is going on or what's going through my mind. And so just because someone is saying or has repeatedly said, I'm going to kill myself, and we haven't seen a suicide attempt, or we're starting to think, oh, here we go again. So-and-so is saying that they may hurt or kill themselves. And what I really want to talk about that myth is every time someone is saying something like this, we should be taking it very seriously. We don't know what circumstances have changed. We don't know what's going on in all aspects of their life. It's hard to know what's going on at home, work, with all of their friends, and even us, for spouses at home and partners at home, we know a lot, but we don't know everything. And so we want to make sure that every time we're hearing any of these warning signs, and especially the big kind of people saying I'm going to hurt or kill myself, that we really take it seriously and we take time to listen, which I'll talk about later, and also provide help or referrals or getting them to the place that they need to be. So that leads us up to, again, what should I look for? What should we look for? And how I really like to break this down, I'm a pretty simple guy, so I like simple diagrams, and this is one that is 4 boxes and 4 different areas, and these are kind of the risk factors that I look for, both as a clinician, but also just working with departments and different first responders, teaching peers, teaching spouses. We teach kind of this risk factor, and the next couple slides I'm going to show you to pretty much anyone that'll listen to us. We want everyone to be on the lookout for aspects of suicide so that we can prevent as many deaths by suicide as we can. So these 4 areas are cognitive or thoughts, our behavior, physical or physiological factors, and then emotional factors. So when we go through this, what I'm looking for with people to kind of look for risk factors, when I think about cognitive or what they're thinking about, I want to think about their self-regard and self-esteem. If someone has low self-regard at baseline when they're not stressed, they're at increased risk for suicide. The 2 big ones that we also see are this cognitive flexibility, and really what that breaks down to are people who have difficulty seeing different views or are really rigid in their thinking. And that pairs really nicely with problem solving. So if when someone's not stressed, they have difficulty problem solving and they're really rigid in their thinking, that's actually seen as a baseline risk factor for a suicide attempt. From the behavior side, one of the biggest risk factors that we have in the suicide research field is that prior attempts. And what I mean by this is people who have 2 or more attempts are at higher risk for attempting suicide in the future. So 0 attempts or 1 attempt actually does not increase the risk, although it still would be on our radar if someone has 1 attempt. We want to really pay attention to those individuals that we know have 2 or more attempts, as they're going to be at higher risk. The second part of behavior that I look for at a baseline risk factor are emotion regulation skills. And again, what I really mean by that is when someone's feeling really overwhelmed by emotion, whether that's anger, which is really common, sadness, any of our emotions, what typically happens is that comes out as behavior. So people who have difficulty regulating their emotions, what we often see with anger is that we may see things like punching a wall, breaking things, throwing things. And so if we're starting to see at kind of baseline people who have difficulty regulating their emotions are again at higher risk for a suicide attempt. And the last thing in behavior is interpersonal skills. And so how people interact with people, again, when they're not stressed. So can they maintain friendships? Do they have friends? Do they get along? Can they have that conversation? From the physical side, the 2 big risk factors that we have in the literature are medical conditions, so long-standing medical conditions. In first responders, I like to highlight lower back pain comes up quite a bit. These chronic conditions that don't always have a cure or a treatment. And then the second thing are demographics. So certain demographics, so we see older white males with access to means, so like access to guns, are at higher risk. And so we want to keep that in mind. And then from an emotional standpoint, I think these 2 go kind of hand in hand, are just a history of psychiatric disorder, so any history of mental health diagnosis. And what we really know, there's some great data that's come out in the last couple of years showing that people who have trauma-related emotional disorders, so thinking PTSD or other traumatic and stressor-related disorders, are at higher risk for suicide attempts. Mental health disorders like depression are often really linked to those thoughts, the suicidal ideation. And so all risk factors, but when we're thinking kind of big red flags, that PTSD one is this disorder that sticks out as a risk factor really for suicidal behaviors. And that goes right along with the emotional ability. So flipping back and forth between high levels of different emotion. If we're seeing that at kind of baseline, again, when they're not stressed, when they are stressed, we're going to see that a lot more. So these are kind of the 4 areas I look at like I said, when I'm training people, when I'm working with people, when I'm listening to people in conversations, when they're telling me about a hard time, I want to see what are kind of their risk factors for suicide. The second thing that I want to look for is what do they look like when they're kind of in their crisis mode? And so what I think about this is when they're really in that heat of the moment, when they're really stressed out, what do they look like? And so up here I put in the same 4 areas: thoughts, behaviors, physical or physiology, and emotion, what a crisis mode might look like for people who are high risk for suicide. So in the thought or cognitive area, a lot of times what we're hearing is, this is hopeless, or it's all hopeless, I'm hopeless, I'm trapped, I'm a burden, I'd be better off, or my family would be better off without me. So we see a lot of these worthless type thoughts that are linked to suicide risk. From the behavior standpoint, again, when they're really in this crisis mode, we often will see some sort of substance use, sometimes alcohol or other drugs. They really withdraw from their friends. They often withdraw from their partners or spouses, even from their crew and from work. And at times we'll see preparatory behaviors, or going to get the means of the way that they want to kill themselves, whether that be a gun, whether that be going out to buy like rope if they're looking at hanging themselves. But that preparatory behavior, writing a note, is another preparatory behavior. So we want to kind of look out for that as well, especially when they're, again, kind of this crisis mode is turned on, or when they're stressed. From the physical standpoint, agitation is huge. Insomnia, or complaining about sleep. So trouble getting to sleep, staying asleep, waking up in the middle of the night and not being able to get back to sleep. Anything related to sleep, we know, is a risk factor for suicide. And then what their pain level is. So typically when people are in crisis, or headed towards crisis, their pain actually goes up. So again, if we use lower back pain, they may start to say, my back is hurting so much, it's feeling overwhelming. That might cue actually a trip to the emergency department, or feeling like they can't go to work. And I only use lower back as one example. There are definitely other things. So we see often that pit in the stomach where I just feel like I'm going to throw up all the time. So any sort of physiological thing related to pain, we see typically increase when people are going into crisis or in their crisis mode. And then from the emotional standpoint, we often hear people talk about feeling down or depressed. This guilt and anger are huge. And so we see a lot of guilt and anger in first responders, especially when they're talking about a traumatic event that happened, whether that's a specific traumatic call that happened to them or happened to their crew or anyone at their work. And so we often hear this guilt and anger, and sometimes shame as well. So those are kind of the things I look at. I look at the risk factors as kind of baseline. What do they look like when they're not in crisis? And then I look at this crisis mode in terms of what do they look like when they're going into kind of that overwhelmed state, or when they're actually in crisis. And so this is kind of the full model here. I know it looks a little overwhelming. It's just the same 2 slides I showed you with one thing in the middle, which we call the trigger or the stressor. So the left-hand side are those risk factors, same 4 areas: the cognitive, behavioral, physiological, and emotional. And what we know is when you have these baseline factors on the left here, to get into the crisis mode or the suicidal mode or the active acute mode, there has to be some sort of trigger or stressor. And so common ones that we hear from first responders are something at work happened, whether that's a call at work or a specific event, financial stress. Almost always it's some sort of perceived loss, whether that's a relationship problem, whether that's a loss of a life or a person, loss of a friendship, so some sort of perceived loss. And then negative memories, often of different events or traumas that the first responder has been exposed to. So once we kind of think and talk to our first responders about what and understand kind of their baseline risk factors, we can't control the triggers. Those come as life comes as part of the job, but we might be able to give them some coping skills to help them with their kind of crisis mode or how they deal with when they go into that suicidal mode. So this is kind of the background that I use for working with everyone that I interact with, whether that's in my clinical work or whether that's just talking to people. I want to kind of understand from a suicide risk perspective, what's going on and how might I be able to help them. The thing that we often don't talk about as much in the suicide literature and even people who present on suicide is protective factors. So what's really cool, or what I find really cool about kind of what we know about suicide, is that risk factors are not on the same continuum as protective factors. They're two different things. And so although someone may be high risk, if they have a lot of these protective factors, they're still overall actually at a low risk for attempting suicide or death by suicide. And so we can often help mitigate some of the risk factors, but we can also bolster the protective factors and give them more protective factors. So the top one that I always like to talk about is this feeling connected with others. This is huge. We know that feeling connected with others prevents suicide. It helps with all mental health disorders, really, and reducing symptoms. And so there are a lot of ways our first responders can be connected. So you, if you're a partner or spouse of a first responder, they likely feel pretty connected to you. And so working on some of the relationship factors and bringing that up when we talk to them can be really important. Family, friends, peers at their work, we know that there's usually a tight-knit work group. And so thinking about all of these factors when we're talking to our first responder is going to be really important. Another thing are the coping skills. So I've mentioned that before. A lot of our first responders have tons of coping skills. And what they often do, like I mentioned, is they forget that they have them. They get stressed out and can't remember that they can do simple things that make them feel better, or they start to lack that motivation. And so I really want to bring that up as something that we can often be aware of and help bring to the forefront for them when they're feeling overwhelmed. Do you remember that you used to work out a lot? Do you want to go work out with me? Then we're bringing in that connection as well as that coping skill. We also know that spirituality and religion can be a really helpful protective factor. I'll save that could be a whole nother talk on how we can use that, but knowing that different, whether it's a specific religion or just that sense of spirituality, has been seen to help protect death by suicide. And then the last thing is access and willingness to go to treatment. So there's a lot of stigma around treatment for mental health, especially within first responder culture. And we know that, and we, as a treatment guy and someone who's working on making the stigma be reduced and reducing barriers, we know that, but it's also understanding what's available for the first responder, and can we get them to the right person? Can we get them to the right treatment? And are they willing to go? And can we work on that willingness? So then I want to talk about a couple things that we can do and make sure that we leave time for questions here. Like I mentioned before, we should be asking the questions. So if we're a spouse or partner of a first responder, we often know a lot about their behavior, and we often pick up on things that change. So that's kind of the first question I ask myself. What has changed? Or what have you noticed is going differently? Oftentimes you may hear about some of the stressors at work, whether that's a specific trauma or just general work factors. The different types of shift work, who you're working with, who's in charge, different things like that affect everyone. And so we want to know and start to notice when they bring that up, how are they changing their behaviors? We can also ask those direct questions. Have you ever had thoughts of killing yourself? Have you ever had thoughts of hurting yourself? We can directly ask those and ask them in an open way because we know it doesn't increase risk for suicide attempts. And it may be uncomfortable for both you and the first responder or your partner, and that's okay. And that's something that we both have to understand in the conversation, that it may be awkward, and how do we deal with that? And I'll give you some tips on that in the next slide or two here. The last part about that is to be patient. It's an extremely hard conversation. There's a lot of stigma related to having those thoughts of hurting or killing yourself, especially within the first responders. And so what we can really do is listen. And this is the top thing that I tell people. If you think about a time where you felt down or upset, and you've called one of your best friends, what do they typically do? They typically listen to your story. They let you talk. They let you, I like to tell my friends, they let me rant when I'm upset, and they just let me go, and they're very supportive, and they listen, and they ask a few questions to keep me talking, and it really helps. Because I get to tell the whole story from my point of view, even though some of it might be, I'll say, a little outlandish or embellished, but I get to tell the story from how I'm feeling at that point in time. We know that first responders don't always have a place to do that, especially about things that they're feeling stressed about, especially if it's about something that happened at work. They may not be able to use people or talk to people as kind of using that as a resource for them, because maybe people at work don't agree with them. And so we want to be able to create that space where they can come home and we're there to listen to them. I always like to mention that we don't have to talk about any specific details, especially if it's about a trauma. If they're telling you about a gory accident, whether that's a fire or medical emergency, we don't have to necessarily have that be part of the conversation, because that can be really tough for us to listen to as well. And what we really want to do is let them express their emotion. And so we don't want to hear the report that they write about the incident, but we really want to hear their perspective and how it impacted them and what's going through their mind, so that they can get it off their chest and talk about it. And so we can talk about this related to suicide. Often when people are feeling, again, that those thoughts of hurting or killing themselves, it stems from a specific trigger. And so maybe we want to go back to, what was that trigger? Tell me what happened. What I like to say about stories is it shouldn't be a beginning, middle, or end. It should be a beginning, middle, and end. So stories have all three parts of these. And sometimes we'll get into a conversation with our first responders and they'll say, Tyler made me mad and I yelled at him and that was it. And there's usually a lot more to that story. Usually Tyler said something pretty specific that triggered the response. And maybe we don't even know what the response was, but we want to hear that whole story, again, giving them that space where they can talk about it and they can express those emotions. And it's something that they're not always used to doing. And that's where we need to be patient and help them and probe for those things. And then again, we actually have some really great data showing that having these conversations or listening to these stories helps reduce suicidal behavior and is very, very protective for these individuals. I always like to talk just briefly about when we're having these conversations, whether it's about a specific event or about suicide or thoughts of suicide themselves, that we respond non-judgmentally, that we don't panic. Again, this is why I want to mention going in prepared for these conversations. This can be a really tough conversation for both sides. And if we come in and say, hey, have you had thoughts of hurting or killing yourself? And our first responder says yes, and we immediately go, well, we should get you to the hospital. It probably isn't, again, going to give them that space, and it's going to be really off-putting for them. They're first responders. They know that if they say some of these things or certain things that they may have thoughts of, those thoughts of hurting or killing themselves, they know what the typical response is. And so we want to make sure that we're giving them that space where our first response isn't that. We want to talk it through, and we'll decide together, with your knowledge and with, going through this, what the best decision is. And through this, we just want to really validate their feelings. It's really tough to have these thoughts and have these overwhelming feelings. And then what are we going to do? What is our plan? And so I'll talk a little bit about that with barriers and at the end here. But what we know in terms of barriers, I talked about this, there's a lot of stigma with first responder culture. They have often thoughts of, I'm weak, I'm not good enough. No one can know. If someone knows, I may my job may be changed. I may not be working what I normally work. And so we know this. That job is really, really important to first responders. It's a part of their identity. And so we want to make sure that as we're having these conversations, that our goal is not, again, we're here to work with them and we're trying to help listen to their story and give them a space to talk and vent about these different things that are directly related to their thoughts of hurting or killing themselves. And then figuring out where can we go? Who can they go to for help? One of the top things that I hear when I work with first responders in therapy is that I've gone to X number of therapists. Usually it's like one. And some of my favorite stories that I've heard over and over again is I left the therapy session, my therapist was crying and I was trying to help them. And so knowing what resources are out there in Florida, in the Orlando area, we have UCF Restores, where we can provide the free treatment, where we know about first responders, we know about a lot about trauma, we know a lot about suicide, and we have a lot of different programs. And so knowing what's out there and getting them to the right person and right program. The last thing here, because I'm looking at time and I know I have a few things to say, and I know there are some questions here, but what can we do to develop a plan? So can we have a plan for when you feel this way? As a spouse or partner, we can ask, what would be helpful for me? Whether that's reminding you of something, what can I do? Because the last thing I want to do as a spouse or a partner is when they're feeling this way, doing something that makes them feel worse. So talking about what can I do to be helpful, is that suggesting things to you, is that giving you space, and then when you calm down, being willing to talk to you and find a time to talk about it. Is it doing something together? Is it, like I said, going to work out, going out to dinner, doing a little bit of distracting when you're feeling overwhelmed until that goes away, and then talking about feeling overwhelmed. Talking about warning signs. How will I know that this is happening? What are your warning signs? Again, we may observe some, but they, as the person who are having these thoughts, often know a little bit more about what's going through their mind. And so we can ask them how to help them. And then again, as I mentioned on the last slide, how can we link them up with a professional if that's something that they're willing to do or something that we think might be helpful? And so ultimately, we want to have a plan. We might have a safety plan, which they may make with a professional, but we want to make sure that they're equipped with different coping skills, reminding them of what their coping skills are, and really taking that time. So I'm going to skip here to the last slide and also mention that this is one of the top things that I talk to with partners and spouses, is that make sure that you have support as well. So we know that if your first responder is feeling overwhelmed, that it doesn't just isolate to them feeling overwhelmed, that it really impacts the relationship. And so making sure that you have support, whether that's professional support or you have the social support to reach out to as well, that you're feeling equipped to have these conversations before having the conversations themselves, and so that you have ongoing support as you go through this journey. So with that, I do have some resources up here from NAMI, the American Foundation for Suicide Prevention, SAMHSA, and the National Suicide Prevention Line that we'll have available in the YouTube video as well as on these slides. And with that, I will open it up to questions.
Thank you very much, Dr. Rosick. That was amazing, especially as someone who teaches mental health myself. Boy, did I learn a lot this evening. Thank you so much for such an amazing presentation. We are still recording. Does anybody or is anybody willing to ask their questions while we are still recording?
I have a question.
Sure.
And I did have to pop out a couple times, so apologize if you did talk about it. But what about talking to your kids about talking? And it could be like older, you know, not necessarily like super young, but like teenage or preteen, about suicide with your first responder. If it's something, you know, in our family, we're pretty open about it. So any suggestions on talking about it with that with different age levels, but like with children?
For sure. Yeah, so I think the big thing that I always mention about with children, regardless of age, is that we make sure that we're not putting any responsibility on them, and making that very clear in the conversation that it's not kid responsibility to keep first responder alive. It's not spouse's responsibility to keep first responder alive, but how can kids be useful in helping cope with some of this? And what I typically say is actually we work that out talking within the couple. So couple talking, again, how can spouse be helpful, or a spouse or partner? And then how could kids be helpful? And so if kids are starting to notice it, what can kids then do? And creating a plan for the kids. So talking to the kids about, you know, some of the warning signs, you know, when you're noticing dad's or mom is getting upset, and sometimes they do X, Y, and Z. So I'll use punching the wall because I worked with someone who did that. That was a big warning sign, that kind of anger again. What can the kiddos do? And for each family, that's going to be different. It could be things like reminding dad of something, or just getting out of there and letting mom know, or spouse or partner know. And so it's including them in the conversation, but making sure then that they kind of have somewhat of a defined role, so that they're not put in a situation where they feel like overwhelmed and I don't know what I'm supposed to do. And I know that mom or first responder has some of these thoughts. So that's kind of my big takeaway, is make sure that they have the infrastructure and that they're aware of what they can do and what kind of their role is, so that they don't take on more than what they really should be.
Thank you. We have a question in the chat box that is asking if our loved one, if our first responder has been to a rehab or has been through some sort of, you know, inpatient program, is there, and that program wasn't effective for that person, how do you start a conversation with someone who's been through the process and they're still maybe having these suicidal ideations or whatnot? How would you start that conversation as the caregiver or spouse or what have you?
Yeah, so usually that starts a conversation about some sort of specific behavior, whether that is the use of the substance, whether that's drinking too much, or whether that's some other behavior that impacts the family. So spending too much time, I'm going to use drinking just as one example. Drinking alone at night and avoiding, basically isolating so that you can drink and not spending time with family. And so how I approach those conversations is I bring up those, or how I'd recommend for a partner or spouse to bring that up, is bring up the behavior. So, you know, I'm noticing that you're spending a lot of time drinking, or, you know, using whatever substance, and I know you've been through a program, but this is really impacting us as a family. And talking about how it is impacting you as a family. And again, this is something that I would prepare for, because going off kind of shooting from the hip or off the cusp of just going for it doesn't always prepare you to have some of those conversations in a non-heated way. And part of that preparation is I would think about what are some other programs or approaches that might work. There's something else out there that we could get you into to try. Are you willing to try something else? Or are you willing to work with me on maybe reducing the drinking or substance use? Again, that goes back to what I was saying about finding the right program for these individuals. And that's something that we at Restores are happy to do we have a pretty solid network in Florida for kind of areas that we don't manage at Restores, but we can also help with a lot of those things at Restores. So going in with that plan and bringing up the behavior of it.
Thank you. Is there anybody else while we're recording that would like to ask some questions before we stop the recording? Okay, with that, I am going to stop the recording now and have a confidential conversation. Thank you so much.